So I'm sorry if there's some technical problems, but I think we've been able to get it going. So let's start. Uh, so over to you, Gautam.
Yeah. Good evening, everyone. So sorry for the delay. We'll be talking on tuberculosis of spine, and we'll be trying to go through the conservative as well as surgical options that we have in spine for tuberculosis. So I hope my screen is visible. So
Yes, sir.
yeah. So why tuberculosis is relevant in India? Because worldwide we know it's one of the infectious disease which causes maximum morbidity and mortality, and India contributes to almost 23% of these cases. Almost 4% of these cases are extrapulmonary tuberculosis, and of these 10% is skeletal tuberculosis. Now, we are orthopedic surgeons, and in this skeletal tuberculosis, 50% are actually spinal TB cases. So that's a big number. So to diagnose any patient, we should be aware of the presentation, what are the symptoms and signs, and then we rule out or diagnose it with some diagnostic test. Initial presentations, we can broadly divide it into as pain. The pain can be would be a dull aching pain, which is gradually getting worse. This pain is more at night time because there is a loss of spasm of the muscles, which causes the uh, inflamed end plates to rub against each other. So that causes night cries. So rest pain is something which is very important. And if it's present, then we should actually investigate the patient in those times in the lines of tuberculosis. Uh, Weakness is another symptoms. So weakness depends on the pressure on the nerves or the cord which is present. So weakness can be in either the upper limb alone or in the lower limb or a combination of both, depending on the site which is affected. And when we talk about weakness, it's not just the motor weakness. It can also be the sensory symptoms. It can, to begin with, if the cord is getting compressed significantly, the patient will complain of imbalance on walking. And in severe cases, there will be paresis or even paralysis of any one limb or more limb. The patient may develop boil bladder symptoms. They may come with symptoms of retention of urine or retention of stool. Another important complaint of the patient would be deformity. So in cases whether it is active COX or in COX which has healed in past, that can present as deformity of the spinal cord, spinal vertebral column. Along with this, the minor symptoms, which can be present uh, would be swelling. The abscess can present as a swelling which can be firm to begin with, and fluctuation can be present. Other symptoms such as fever, weight loss, loss of appetite may or may not be present. Weight loss is not an important criteria to be always present in spinal tuberculosis. So when to suspect that the patient might have some uh, uh, serious disease like tuberculosis. So there's various red flags. So these red flags can be severe pain, which is affecting the activities of daily living. Thoracic pain. Now this is very important. Why thoracic pain? Because back pain, lower back pain, and neck pain, these are mainly mechanical in nature. The thoracic spine is actually guarded with ribs. So if the pain is occurring in thoracic spine, it might be something very serious affecting the vertebrae. So one should be very cautious whether it is if it is a lower back or mid back or upper back which is getting affected. So thoracic pain is actually red flag sign. Neurological weakness, knuckle in the back, that's deformity. Significant weight loss. Now significant weight loss means at least 5 kgs in a span of 1 month. Swelling, which might be paraspinal, inguinal region, or in axilla. So diagnosis chief mainly based on clinical symptoms plus radiological investigation and biopsy. In this radiological investigations, the basic things that we need is X-ray, MRI, and at times CT scan. So this is a pic of X-rays. So what can we actually make out here? In the very first pic on the left side, if we can, what has been marked is decrease in disc space. So this is a very classical pic, X-ray pic of a paradiscal spinal tuberculosis, spondylodiscitis. The disc space reduces, and at times there is even destruction of the end plate, which is visible on the lateral view, and even on the AP views X-rays. The next pic, the second one, we can appreciate that there is a loss of pedicle on the uh, left side. So this is typically called as winking owl sign. Now, if we see any vertebrae from in AP view, there are two pedicles, and the spinous process, which looks like the spinous process looks like a beak of the owl, and the two eyes are the pedicles. The two pedicles are the eyes. So if the pedicle is destroyed along with the posterior element, this is called, this is how it looks like, and that's called a winking owl sign. The next pic uh, below it, it shows that there is destruction of the posterior element, which has been seen over here. The pedicles are destroyed, and the pic on the fourth one, we can see that we can appreciate that there is a deformity. There is a kyphotic deformity because of multiple vertebrae involvement and destruction of the vertebral body. And this is what we see on an MRI. So in MRI, in a typical pic, the very first pic, we appreciate that there are there are three vertebrae which are involved. There is a destruction of the vertebrae with with prevertebral abscess, and there's some abscess compressing on the cord. So epidural abscess. So, very sorry for this interruption. So they have vertebral column which is destroyed. There is prevertebral abscess which we see. There is epidural abscess compressing the cord. The cord is getting kinked, and if we can appreciate posteriorly, the spinous process are getting distracted. In the very next pic, there is a T2 weighted image and a T1 weighted image placed simultaneously. So this is how a typical abscess will look like. If it's a wet lesion, on T2 it will appear bright, and on T1 it will be hypo intense. And on stir, if the lesion is active, it will appear hyper intense, as has been seen in the C pic. So this is how the typical, yeah, this is how a typical tuberculosis is present. Axial view is very important, as been shown here. There's abscess which is shown, which has been seen in the prevertebral region, and also the epidural cuff is getting obliterated because of the abscess. So not only the sagittal, we have to see even the coronal as well as uh, the axial films. Once we appreciate this, then the final diagnosis, which is the confirmatory diagnosis, that is being made only by a diagnostic biopsy intervention, that is biopsy. So always ask for a biopsy. Either a radiologist or the treating surgeon should do biopsy of that lesion. It can be the pus aspiration or the bone biopsy. Why it is important? Because many times there are various other pathologies like metastasis, myeloma, which mimic a tuberculosis. So there have been instances, even my own cases, I have seen that whether when we were suspecting tuberculosis on diagnosis, it turned out to be metastasis and vice versa. So there are various conditions that will actually bluff you. So final diagnosis is always based on biopsy. So if and when the patient is not willing, that's the only time that one should start empirical ATT. Otherwise, always try to do a biopsy, obtain a biopsy, and then proceed further. So once the biopsy has been done, then the question arises as to what is to be done. Whether the patient, and we have the diagnosis. So if you have the diagnosis, the patient is with you, the patient has come, you have confirmed it with the biopsy, then we need to decide whether the patient needs surgical intervention or it can be treated conservatively. Now remember, 95% of these patients, they will actually get better without surgical intervention. It is only 5% of the patients who will actually need surgery in some form or the other. So the criteria to decide the management should be based on first neurological status. So deformity is the second, then the site of the lesion and age of the patient. So these are important parameters we should consider for deciding the management. So if there is a significant neurological deficit, yes, we should operate on the patient. Deformity, if it is already present or it is impending, surgical intervention. If the tuberculosis is affecting some junctional area like C1, C2 region, occipital cervical region, or C7, D1. So as the disease goes on to heal, there's always expected to be there be some collapse in the diseased vertebrae, and there will some deformity at the end of the healing. So if it is suspected that the end result will lead to significant deformity or significant instability, then such junctional areas should also be operated upon, because these are actually very painful to begin with, and they usually don't respond to non-surgical management. Age of the patient, that's another important thing. Why it is important? We are not in the adults, but in kids. So if there is a significant deformity which is seen at presentation in a child, then remember there are times when the kyphosis is actually going to increase over a period of time. And as the age increases, as the child grows, the deformity is further going to get exaggerated. So if a child comes at the age of 7 years and there is a slight 10 degrees kyphosis, it might get into 110 degrees by the time the child reaches adolescent age group. So in children, we have to be extra cautious. And there are various signs proposed by Dr. Raj Shekharan, which has to be taken into consideration. So the indication of non-surgical management would be actually what a contraindication for surgery. So indication for surgery is something which we should be aware of, and whatever we are not able to operate, that should be conserved. So the indication of surgery are tense neurodeficit either at presentation or neurodeficit which is getting worse over a period of time, or which has appeared while the patient is on treatment. Same thing for deformity. A deformity very significant to begin with, or which is occurring during presentation, which is an impending deformity. These need surgical intervention. And kids sign the spine at risk sign proposed by Dr. Raj Shekharan, that is to be taken into consideration. Another important indication for surgery is instability. Now, instability means the patient is having pain on getting up from bed, change of posture, standing, sitting, bending forward. All these movements in which the spine is at stress, that is painful and is disabling. So if standing, sitting, walking is disabling because of the actual pain which gets worse on change of posture, then it's indicative of clinical instability. This has to be correlated with X-rays and radiological instability, and then the patient should be offered surgery. So when we talk about non-surgical management, the management includes complete bed rest for a period of 3 to 6 weeks, depending on the condition of the patient. Another important factor is TB medication. Now, remember, there are first line of drugs and second line of drugs. We will see that eventually. Then analgesics, steroids, if and when needed. Diets, that is very important because a protein-rich diet, a diet which is not interfering or loading the liver, because the liver is already a stress because of anti-tubercular regime. These are to be taken care of. Calcium and vitamin-rich supplements should be added, and most importantly, the patient and the family members should be educated. So, what this education is about? The education about when to meet a doctor at the earliest. So, the patient is supposed to be educated about how the drug is to be taken, that the urine color will change because of the drugs, that there might be some vomiting. These are the education part. Also, the patient should be instructed to daily monitor their movements of the legs and the upper limbs. And if they feel there is some deterioration, they should meet the surgeon, doctor, as early as possible. Regular follow-up is a must because in India we face a problem of loss of follow-up. So, and we have to sensitize the patient regarding the tuberculosis drug, that it has to be taken on a regular basis. It should not be missed. If the patient is also taking medication for hypothyroidism, then we should ask them to take that medication afterwards, after taking the anti-tubercular drugs. So these are the small tips which we should educate the patients with. So the rest I have already enumerated. So, and these are some examples as to how the patients who have been treated without surgical intervention, they have responded. Cox spine, which has involved multiple vertebrae at lumbosacral junction. She responded very well to non-surgical management, and this is a, this is her CT scan at 15 months of follow-up, showing good healing, and there was no instability. Another patient with spinal tuberculosis affecting the cervical spine. So remember, tuberculosis medications, the primary first line should be HRZE. There is no S in this. So rifampicin, isoniazid, pyrazinamide, and combutol. So these are the 4 drugs which we are supposed to administer to the patient, and it's not vaguely to be given. We should always give according to the weight of the patient, and this is how you should remember: HRZE 5, 10, 25, 15 milligram per kg body weight. Now, second line of ATT is actually uh, for those patients who are not responding to tuberculosis first line of medications. And there are various drugs. And earlier it was proposed to have various regime. There might be short-term regime, long-term regime, but that has been modified. And there has been WHO guidelines which has been coming up again and again. Right now, what with the advent of newer drugs, all the TB drugs are being classified into 3 groups. Group A, it has linezolid, levoflox, and bedaquiline. So I remember it as acronym as LLB. There is a group, so all the 3 drugs of this group A has to be included. Now, group B, that includes clofazimine, cycloserine. So any one or both medicine is to be included. And group C, the other medication which has got some efficacy, it might be these are more of bacteriostatic drugs: the combutol, delamanid, pyrazinamide, imipenem, meropenem, amikacin, ethionamide, PAS. So all these medications are to be given to the patient, and the regime should be to at least give 5 drugs. So minimum all the three of. So if the patient is not sensitive to the first group A, then we have to again go to the B, and then if need be, go to group C drugs. The point is to give at least 5 drugs of this uh, regime. 5 drugs is to be given, and depending on whether the patient has been exposed to these medications in past or not, the various short-term, the regime is decided. It can be either a short-term regime or it can be a long-term regime, short-term of 12 months versus long-term of 18 to 24 months. So there are various criteria which are actually taken into account. And as a surgeon, you are not supposed to administer this second line regime. Please remember this is to be given by a chest physician, and because bedaquiline is not available in private practice, we have to refer all the drug resistant tuberculosis patients to a government setup. There are various side effects of these anti-tubercular drugs. It can affect the liver, the kidney, lead to hearing loss, visual loss, gastritis, loss of appetite, and minor symptoms like nausea, vomiting, and serious symptoms like cardiac arrhythmias, liver failure. These are life threatening. It can happen in some drugs. So always be in touch with a good chest physician whenever you administer TB medications. So if the most common symptoms that the patient present with as a side effects of anti-tubercular drugs is derangement of LFT, which leads to nausea, vomiting, and loss of appetite. At times, it also leads to icterus. So the point is, then we have to measure the LFT. Suppose it is deranged, then we should accordingly stop rifampicin, isoniazid, and parazenamide, and start on some uh, other medications like injection streptomycin and levofloxacin. After this, after you modify the drugs, then again repeat the LFT for next at 10 to 15 days interval till it normalizes. Once it normalizes, then we should again start with this rifampicin. Again check LFT. If it's getting better, add isoniazid. If that also the patient is able to sustain properly, then add parazenamide. So this is how you go on adding anti-tubercular drugs in a patient who is actually having uh, liver derangement followed by uh, after anti-tubercular drugs. So another important factor in non-surgical management is regular follow-up. So the regular follow-up should be initially at 15 days interval with LFT, and after that every monthly for a minimum 3 months, and then you follow up the patients till the patient is not declared healed. During each follow-up, the patient should be examined clinically. The liver function test is to be done, and X-rays is to be repeated. Patient education, I have already informed. Now, we have spoken about second law of ATT. So second law of ATT is actually to be administered in patients who have got drug resistance. Depending on how many drug the bug is resistant to, it can be a monodrug resistant, or if it is resistant to rifampicin and isoniazid, it is called as MDR, multi-drug resistant. If it is resistant to all the first line, it is called as complete extreme drug resistant, or at times it can be total drug resistant tuberculosis. So depending on how many drugs the bug is resistant to, we need to classify that and accordingly start those second line of anti-tubercular medications. In India, the drug resistance is almost as high as 10% of prevalence, and hence irrational anti-tubercular medication is to be something which is to be discouraged at every level. Another reason for anti-tubercular medications getting resistance is patients not taking the adequate medications in adequate form and on a regular basis. So regular basis that we have to educate the patient, and the right dose that is to be decided by the physician. So how to diagnose whether the patient has MDR or not? One is the biopsy that we initially do. And secondly, while the patient is on treatment, if the patient is taking medication properly, still the patient is having uh, worsening of the symptoms, or the patient has got some comorbidities like HIV or immunosuppression and is not responding adequately to this medication, then we should suspect MDR TB in such cases, and for which we have to do again a biopsy of the patient, send it for gene expert and AFB culture. So this has to be done. Another important aspect of starting of anti-tubercular drug is when to stop. So this is very important question, and we don't have a definite answer as to when to stop, because earlier the regime was to just give it for 2 years. Then there was like 18 months regime. Then there was a Hong Kong regime for just 6 months short term regime. So what we do, or actually we do practice in our clinical practices, we repeat the MRI at 9 months, 12 months, 15 months, and so on every 3 monthly, and see for the changes. So the changes which made us to diagnose tuberculosis, the same changes, if they are reversed and there is fibrosis or fatty replacement of the marrow, disappearance of the edema, and disappearance of the abscess. So these are the criteria which help us to know that the TB is actually getting healed, and then we have to stop the anti-tubercular drugs. So the healing should be based on symptom, signs, and imaging. And as a surgeon, we have a very definite but a very small role. That is something we should remember. So the indications I have already enumerated: dense neurodeficit at presentation or deficit which is occurring during management, deformity which is very significant to begin with or occurring during treatment, kids who have got spine at rest sign, or patient who have got significant instability while being treated. So these are the relative indications for surgical intervention. When even after repeated biopsy, we are not able to have a proper diagnosis. So that can also be an important reason as to why to have an open biopsy. Because many times, as I told you, there are diseases which can mimic TB and vice versa. So we should be well aware of such things and accordingly make the right choice. So again, the same thing, indication dense deficit. When we talk about deficit, the deficit can be either because of the acute wet lesion in which the granuloma or the abscess is the cause, or it can be a healed TB and there's a deformity or internal gibbus which is leading to to cord stretching, leading to paresis and paraplegia. So you should be aware of having encounter or have of patients who develop neurodeficit not only when the disease is active, but even when the disease has healed, but with deformity, the patient can develop neurological deficit. So the indication, another indication is instability. So clinically, all the patient have got deformity, some pain at rest to begin with. They have got pain even while standing, sitting. So, but we should always wait and watch, try out conservative management. And if it's not healing properly, the pain is persisting. The radiologically, it's showing that the uh, bony end are being destroyed. The patient is not able to heal. Then we should go in for surgery in those active cases. In healed cases, we should check out the deformity. How is the sagittal alignment? How is the coronal alignment? Whether that is impinging upon the normal gait on the normal stance of the patient. So that, and if it's interfering, then that's the reason for the patient to have pain, and that's the instability in a healed lesion. So that which warrants surgical intervention. And this is a spine at rest sign proposed by Dr. Raj Shekharan and team. So in this, there are 4 signs which we should be aware of. This is specifically seen in kids. So if even in the early stages, you come across patients in which there is separation of the facet joints or posterior retropulsion of the deceased vertebrae. There's a lateral translation of the spinal alignment or toppling of the vertebrae over the lower normal vertebrae. So these are the four risk signs. So if these are present in at any stage of an active disease in a child, the child is bound to have significant deformity, and this is more so common at thoracic spine. Once it heals in significant kyphotic deformity, the patient will definitely have neurological symptoms, and hence it warrants a surgical intervention, because correcting this deformity is much easier when the disease is wet, because you can correct it very well. The trick is stabilizing it. The stabilizing it in wet lesion is actually more tricky than as compared to when the spine when the disease has healed. But correcting it becomes very easy if the disease is partially healed or partially wet. Now, this instability phenomena that depends on the bony destruction, muscle condition, and also neurological status, as well as the site of the disease, that is junction. So every TB spine is unstable to begin with. We should always try to have a conservative management. Whenever it fails, we need a surgical management. And this is the basic concept of the middle path regime proposed by Professor Tooley sir. Deformity, spinal deformity, the most common thing that we come across is the kyphosis, because it's more common in the thoracic spine. The thoracic spine itself is very kyphotic to begin with, and end plate destruction and loss of the musculature, or the tensioning of the muscles, that further aggravates kyphotic deformity. As I mentioned before, this kyphotic deformity can be seen in during active disease, in which there is a mobile wet lesion, a mobile apex is seen, so easy to deal with at this stage. Or the deformity, kyphotic deformity, can be seen in a healed lesion, which is having a rigid apex. This will be difficult to begin with, difficult to deal with, and it needs more training. A learning curve is more uh, longer in such cases. So this is one thing which is commonly asked in even during YY, as to why there is significant kyphotic deformity in thoracic spine. Because to begin with, the thoracic spine has got kyphosis. Tuberculosis usually affects the thoracic and the thoracolumbar junction. There's destruction of the body and the disc, so the anterior column is being lost. There's stretching of the facet joints and the ligaments, and also the tension band phenomena of the muscles is being lost. And after a particular time, the muscles, the posterior spinal muscles, instead of pulling up the vertebrae, it increases the kyphosis. Once the kyphosis increases beyond 40, beyond 60 degrees, so 60, 70 degrees of kyphosis, the muscles are more anterior to the apex of the deformity, and they further lead to exaggeration of the kyphosis. And also in child, as the child grows, if the child has got some kyphotic at the beginning, at a younger age, and the anterior end plates are healed in kyphosis, then only the posterior elements, they go on increasing in height. The anterior, there is tethering of the anterior growth plate that exaggerates the kyphosis in a child who has been affected with tuberculosis. So these are various symptoms which we associate with kyphosis in any individual, and the most important thing is which leads it can lead to neurological symptoms, and there are various ways how to correct the kyphosis depending on the amount of kyphosis. The various modalities osteotomy can be applied. There are various. This is a chapter in itself. So if you just remove the facet joints on both the sides, it's called a spontaneous osteotomy. When you remove the posterior element along with the facet joint, it's called as Smith-Peterson osteotomy. If you go through the pedicles and remove a wedge from both the sides, it's called as pedicle subtraction osteotomy. Or you can achieve a milder form of same thing, which is called as transpedicular decompression. a combination of various of these things, and can be called, we can even do a larger corpectomy, that is vertebrectomy. So all these things are there, and this itself is very complex thing. The end result should be that the cord is decompressed from all the sides, and that there is bone to bone contact, right, in the front, as well as being hold from the posteriorly. So these are various specs in which I have tried to show some forms of osteotomy. And a combination of various things. You can either remove a facet or a posterior element, Smith Peterson. This is a pic depicting all these things. Various combination of these things can be done. So this depends on how much correction is warranted in a particular case, and what's the deformity to begin with. Where is the deformity, the site of the deformity, in which all areas it has involved. An important thing for a surgeon is surgery. If we have decided when to operate, the timing depends on why we are operating. Whether it's a deformity or it's instability, then it can be elective surgery. If the patient has got impending deficit, you can plan it well, operate in a day or two as a semi-urgent case. If the patient has got severe neurological deficit to begin with, or even during or deficit which is happening while the patient is on treatment, then we have to be as urgent as possible. And the approach can be either anterior, it can be posterior, it can anterior posterior. That depends on where the lesion is, what is your approach of the surgeon. What usually nowadays we are more familiar with the posterior approach, and through posterior we are able to do all the tackle the anterior things also. It is easy to begin with, easy to proceed, and a very friendly approach. Another thing is implantation. So unless and until we are doing only posterior laminectomy, whenever we are touching the facets, whenever we are doing corpectomy, it has to be supplemented with instruments. That's a must. And instruments in tuberculosis or infection is not a contraindication, because these mycobacterial films are not seen on the titanium implants. So very well we can put implants. It can be a simpler, very cheap implants, which used to be like sublaminar wire and hard shell in the past, or it can be pedicle screw. But remember, the technique has to be proper. You have to master technique, because if you use the good tool but you don't master technique, you can end up with something like this. This is a pic which I have taken from my Mumbai experience in a big multi-specialty hospital. This poor child, he was instrumented with pedicle screws right into the cord, and he actually developed neurological dense neurological deficit post surgery. So not only knowing, having the good implants, how to use the implants in the to the best of your knowledge, to the best for the best outcome, that is to be mastered. This is another case in which we have done deformity correction and she later on, means earlier we didn't have biopsy proven in this case, because she came with dense neurological deficit and we have to go in. She turned out to be MDR tuberculosis, and we had a hell lot of problem in treating her eventually. This is another pic of a girl who had a MDR tuberculosis, failed implants with significant kyphotic deformity. We had to go in again. This was operated somewhere else, but we had to go in again. This is typical what even Dr. Raj Shekharan has mentioned. So if they have got deformity right at the age of in childhood, like she was in 7 years, this deformity, which is roughly around 80 degrees now, would have translated anywhere under around 150, 160 by the time she was a teenager. So this is how we had proceeded. We had done a complete corpectomy, had an anterior reconstruction, and then posterior stabilization done for this child. She was 7 when we operated, and now she is 14 and doing well.
Yeah, excuse
Another,
me, sir.
sorry.
Uh, yes, sir. Actually, there is one meeting of sir now.
Right, right. So we are
So
done. We are
because
done
it's
basically. Yeah, yeah,
yes, sir. So if you can summarize this.
yeah. So tuberculosis is something which is very important thing to begin with, not only in your exams but also in our practice. And tailored made treatment should be always offered to the patient. Always try to conserve them. If not, surgery is to be opted. It has a very specific and a definite role in tuberculosis. So, if there are any answers, questions, I would like to answer.
Yes.
Yeah.
Okay,
Uh,
so thank you very much, Dr. Gautam. If there are any questions, please ask them from all the delegates, all the participants.
Yes. If you have any doubt, please ask. I think. Okay,
Should
sir.
not feel shy to ask questions at this stage. Huh? So I think we're going to have to talk to them tomorrow.
Sir.
Because anyway, thank you very much, Gautam. I think we have another meeting starting in another 5 minutes, so we'll have to call it a day today.
Yeah.
And so thank you very much, and bye, everybody.
Thank you, sir.
Thanks.
Yeah, sure. Thanks. Okay, bye.
Thank you, sir.